Good morning, everyone. Good morning, sir.
Good morning. So, all good?
Yes, sir. All good, sir.
Very nice. Things are progressing well?
Yes, sir. Yes, sir.
Good, good, good. Very nice. Nice to see your smiling face in the morning.
Thank you, sir. Same to you, sir.
God bless. So, I'll remain muted. Okay. Yeah.
Yes,
I'll
yes.
start in time. Thank you.
Joining from the main screen. In the meantime, you can on the laptop and you're on. Yes, yes. Good morning, ma'am. Good morning. Good morning, ma'am.
Hello. Good morning. Yes. Good morning, everyone. It's 8, I think. We can start.
Good morning. Makansha, please go ahead.
So, shall we begin with the...
Yes. Good morning, ma'am. Good morning, sir.
Dr. Chinmay, shall we start?
Yes, ma'am. Yes, ma'am. So I request everyone to please pray with me. Oh God, bless us,
Oh,
Oh,
God.
God bless us,
so that we not harm anyone.
so that we shall not harm anyone.
We shall do good to others.
We shall do good to others.
We shall try to learn at least one thing new in a day.
We shall try to learn at least one new thing in a day.
We shall try to become a better communicator.
We shall try to be a better communicator.
We shall try to become a good time manager.
We shall try to be a better time manager.
We shall be truthful to ourselves and to others.
We shall try to be truthful to ourselves and to others.
We shall try to become a better human being.
We shall try to become a better human being.
Oh, God
God bless us.
Oh, God bless us. Thank you.
Good morning, everyone. I welcome you all in this new World NHISGI session, in which there will be two meetings today and at the end of the month. Today, 3 institutes will be presenting the hymns for early and late onset sepsis etiology, resistance pattern, and empiric choices, followed by AIMS Bilaspur on predicting sepsis early, and followed by Little Ferns. Then there will be a Greenet talk by the graphic era team. I'll request Dr. Deepak to please take over.
Yes, sir. Am I audible, sir?
Yes, Deepak. Please go to the presentation view.
Yes. Good morning, all. Today I will be
Deepak, you're not audible.
Good morning, sir.
Yes, please go ahead.
Yes. Good morning, all. Today I will be presenting the topic neonatal sepsis. My moderator is Dr. Diksha Gupta, ma'am. My specific learning objectives are the understanding of the global as well as Indian burden of and epidemiology of the neonatal sepsis, classify and identify the risk factor and clinical features, recognize the common organism and antimicrobial resistant pattern, and outlining the antibiotic policy and management, including the multi-drug resistance infections. Firstly, you see the global burden. In the first week of life, the sepsis accounts for about 8% of the all neonatal death. It is because competing causes such as intrapartum events and prematurity accounts for a larger absolute number of the deaths. And after first week, the sepsis is the dominant cause of the neonatal mortality, accounting around 37%. And in developing countries, it is the second most leading cause of a neonatal death. And in India, it accounts a leading cause for after prematurity. It is a leading cause for neonatal death. In India, the neonatal sepsis population-based clinical sepsis in India varies from the 5 to 170 per 1,000 live births. And the hospital-based culture-positive sepsis in India is 16 per 1,000 live birth. And of these, the 1/3 die. And in rural community-based culture-positive sepsis in India is 4 per 1,000 live births. In hospital, approximately 9% of the sepsis cases have proven meningitis. And there is very high rate of multi-drug resistant sepsis, especially related to the Acinetobacter. Danish study, it is one of the largest study conducted in India in 3 centers in Delhi with the 13,500 enrolled neonates. The incidence of total sepsis reported of 14.3%, with the culture positive sepsis 6.2%, of which early onset sepsis 2/3 and late onset sepsis are 1/3. Most common organism being gram negative, which of Acinetobacter, Klebsiella, and E. coli. And gram positive also predominate, of which coagulase negative Staphylococcus aureus and Staph aureus and Enterococcus. They have reported both similar organisms in the early onset and late onset sepsis. And case fatality rate is around 25%. Neonatal sepsis, some terminologies. Definite, when we say the definite sepsis, the growth of a non-contaminating bacterial organism in the culture from a sample drawn from an otherwise sterile clinical site. When we say the probable sepsis, it is a clinical syndrome in the presence of laboratory markers of the systemic inflammatory response and sterile culture. When we say possible sepsis, when there is a clinical syndrome suggestive of infection in absence of positive culture or biomarker of systemic inflammatory response. Then how we classify in early onset and late onset sepsis. Early onset sepsis present at or before 72 hours of life. It may be symptomatic at birth, manifest with the respiratory distress and pneumonia. Source is maternal genital tract, and the mode of transmission can be transplanted placental spread or ascending infection after rupture of the membrane or exposure during the delivery via infected birth canal. In case of late onset sepsis, that is after 72 hours, it presents with the septicemia, pneumonia, and or meningitis. It can be hospital-acquired infection. It can be a community-acquired infection. In case of hospital-acquired infection, the risk factors were prematurity, low birth weight, mechanical ventilation, invasive lines, and parenteral fluid use. In case of community-acquired, there will be a poor hygiene, poor cord care, bottle feeding, pre-lacteal feeds. Then how we classify the risk factors? Red flag risk factors and yellow flag risk factor according to the ICMR STW guidelines 2022. Red flag risk factor will be the age of the baby is less than 7 days and the mother has a foul smelling liquor or choriamnitis. Yellow flag risk factor are unclean vaginal examination, dye handling, or rupture of the membrane for more than 18 hours, and preterm premature rupture of the membrane, urinary tract infection, or diarrhea and fever to the mother. Then clinical features, red flag clinical features will be shock, sclerema, respiratory distress needing intubation or Silverman-Anderson score of more than 6, bleeding from the multiple sites, or respiratory distress onset more than 6 hours after birth. And yellow flag clinical features will be a seizure, refuse to feed, heart rate more than 160 persisting for 1 hour despite of normal temperature, respiratory distress, floppiness, or fever or hypothermia not due to environmental temperature, new or increased apneic episode, lethargy, feed intolerance. When we say the probability of sepsis will be high, any of the red flag sign is present or two yellow signs, that is maternal risk factor, are present, one yellow sign or maternal risk factor present, and the baby's age is less than 32 weeks, then we start the treatment and investigate. When we say suspected sepsis, if there is one yellow sign or maternal risk factor is present and the baby's gestational gestation is more than 32 weeks, then we can observe. The organisms. In case of early onset sepsis, the Danish study showed that organism will be the Acinetobacter number 1 and followed by Klebsiella and E. coli. And in case of neonatal National Neonatal Perinatal Database study conducted in 2007 and 8, first most common organism can be Klebsiella pneumoniae followed by E. coli and Staph aureus. In case of late onset sepsis, organism in Danish study similar to the early onset sepsis, and in case of NNPD study, the first organism will be the Klebsiella followed by Acinetobacter and cons. This is the New York study conducted in 19 hospitals across the world in developing countries, including India, in 2023, published in PLOS Medicine, and they have enrolled around 3,200 of the babies. In India, the sites were AIMS Delhi, GFMR, KM Hospital, and Lady Harding Medical College. They have also showed that Klebsiella is the most common organism, followed by coagulase negative, Staph, and Acinetobacter. In as we see, in first 3 days, the organism, that is Acinetobacter, is predominant, and after 3 days, that is late onset, the organism will be the Klebsiella pneumoniae is predominant. Then NICU antibiotic policy. When we prepare the antibiotic policy, the requirement is minimum around 12 months of blood culture data is needed, and we stratify by early onset and late onset sepsis. For each organism, we first calculate the sensitivity of each antibiotic. Then followed by steps 1 is identify the top 3 to 5 pathogens contributing around more than 80% of the infection. And step 2 is first line antibiotic selection criteria, that it can cover around more than 70 to 80% of the cumulative sensitivity. And how to calculate it? By weighted sensitivity of the chosen regimen against common isolates. And we have to narrow down the effective spectrum and avoid the carbapenems, routine vancomycin, and high resistance cephalosporin. Then step 3 is selection of the second line therapy. When there is no clinical improvement at 48 hours, high-risk babies such as shock, ventilated baby, and ELBWs, it cover around more than 80 to 90% of sensitivity coverage. And third line therapy, that is reserved drugs, it should be used indicated when culture proven multi-drug resistant organism and failure of the second line therapy. It should cover around more than 90 to 100% sensitivity. And step 5 is also important, that is de-escalation, that is antibiotic stewardship. And first review the antibiotic at 48 to 72 hours. If culture is available, narrow down the therapy, and if culture is negative, consider stopping the therapy. Then in early onset sepsis, according to NNF and WHO, first line antibiotic recommended is ampicillin and gentamicin, but the strength of recommendation is very weak, and there is very low in certainty of evidence, as there is inconclusive data regarding this. And in case of late onset sepsis, the antibiotic policy should be based on the local organism profile and resistant pattern. The evidence-based principle will be the ideal empiric antibiotic should cover most common pathogens without providing unwarranted selection pressure for resistance. The risk factors for the multi-drug resistance organism will be prematurity, especially ELBW babies, poor sepsis technique, invasive procedure, prolonged TPN, prolonged ventilatory support, presence of indwelling catheter, inappropriate use of broad-spectrum antibiotic, primary infection with the drug resistance organism, wrong choice of antibiotic. I will be covering briefly about the antibacterial resistance. In this chart, we should on the x-axis showed the different categories of the organism and resistant pattern, and on the y-axis represents the percentage of case fatality. The bar represents the data from the different studies. As we can see, there is a that's a significant proportion of sepsis cases are culture positive, but there is also a considerable number of culture negative cases also, highlighting the diagnostic challenge. And for staph aureus, there is high proportion of the MRSA indicating significant resistance even among the gram-positive organisms. And in case of Acinetobacter, there is large proportion of isolates or carbapenem resistance. This data from the NeoOp study, they have also showed the Klebsiella pneumoniae showed a high resistance for the third generation cephalosporin and gentamicin, and the emerging resistance is for the meropenem. And in case of Acinetobacter, there is extremely high resistance also for the meropenem. And in case of E. coli is comparatively better sensitivity than the Klebsiella for the third generation cephalosporin, and piperacillin and tazobactam is highly effective against the E. coli. Then this study conducted in India at 5 district hospitals, center study, prospective cohort study, enrolling around 6,600 neonates with the mean gestation of around 37 weeks. It showed that data from the this study is most common organism being Klebsiella, followed by E. coli and coagulase negative staph. And there is data showed that first Klebsiella pneumoniae and E. coli, there will be high resistance to the third generation cephalosporin and beta-lactam and beta-lactamase inhibitor combination. This suggests that the high prevalence of the ESBL producing organisms, and in case of Acinetobacter, showed very high resistance even to the carbapenems, which is extremely concerning. So across all organisms, resistance to the commonly used antibiotic is high, leaving the limited scope for the treatment options. Then choice of antibiotic. The choice of antibiotic depend on the unit specific microbiological data, type and site of infection, severity of the illness, and antibiotic previously received. I will be shortly covering the choice of antibiotic. In case of extended spectrum beta-lactamase producing enterobacteria and AMC beta-lactamase producing bacteria, the choice of that is preferred drug is carbapenems first, and not preferred drug is piperacillin tazobactam and third generation cephalosporin. Cefepime is not preferred as ESBL organism hydrolyze the cefepime. And in case of piperacillin and tazobactam, the tazobactam concentration is very low as compared to piperacillin. That is, tazobactam is to piperacillin concentration is 1:8. And in second line, we can use this carbapenem resistance. In case of carbapenem resistant enterobacteria, we prefer the drug ceftazidime and avibactam, and not preferred drug are the meropenem and tigecycline. And tigecycline should not be used as a single line therapy. It should be always used in combination with along with drugs such as colistin. And third, Carbapenem-resistant Acinetobacter baumannii. For preferred drug is cefoperazone sulbactam and combination of meropenem and colistin. We should avoid the monotherapy with the meropenem, colistin, and cefiderol. And third is MDR or DTR, that is difficult to treat resistant Pseudomonas. The preferred drug is ceftazidime, avibactam plus aztreonam. And you should not use non-susceptible beta-lactams and carbapenems. This data is from the IDSA 2024 guidelines. Thank you.
Morning, greetings from AIMS Bilaspur. On our behalf, Dr. Mona Lisa, DM residents will be presenting on predicting sepsis early, other than CRP.
Good morning, respected seniors. My topic for today's presentation is predicting sepsis early, clinical scores and biomarkers beyond CRP. Objectives of the topics are: one, validated clinical score, how to apply in bedside; three, biomarkers, user procalcitonin, IL-6 and neutrophil to lymphocyte ratio; the decision rule, which biomarker to add when CRP is equivocal. First of all, why we need clinical scores for early onset sepsis? Because in sepsis, the symptoms are mostly non-specific. Many times it overlap with other conditions like respiratory distress syndrome. And the symptoms, signs are certainly at the early point. And for the clinical importance of immediate trials, reducing the empirical antibiotic overuse. This is the clinical decision support tool, that is Kaiser Permanente Neonatal Early Onset Sepsis Calculator, which is used in many countries, especially in US, to detect the probability of neonatal early onset sepsis based on the maternal risk factors and the infant's clinical presentation. This calculator is specially applicable for neonates born at or beyond 35 weeks of gestation, which is important to remember when considering its use in different clinical settings. Using this model, the clinicians can quantify the risk of sepsis per 1,000 live births and make more evidence-based decisions regarding investigation and antibiotic initiation. The advantage of this tool is that it helps reduce unnecessary antibiotic exposure while still maintaining the patient safety. The original Kaiser Permanente early onset sepsis calculator has been derived from the data on infants born between 1993 to 2007 in the Kaiser Permanente cohort in US and is published first time in 2017. This is the latest update in 2024. When we'll go to Google and we'll just enter the Kaiser Permanente calculator, it will show this picture where we can enter the predictors and to calculate the risk. In predictors we can enter are incidence of early onset sepsis, gestational age, the highest maternal temperature, rupture of membrane in hours, maternal GPS status, whether it is negative, positive or unknown, and the type of interpartum antibiotics like broad spectrum or GBA specific antibiotics. And after entering these predictors, you can just click on the calculate where it will show the risk per birth. Depending upon the clinical examination, within first 24 hours after birth, whether it is the baby is well appearing or equivocal or clinical illness is present, the risk shows per 1,000 birth and the clinical recommendation whether to give antibiotics or not and the vital parameters to monitor. So before going into testing how to apply in the bedside, we should know the clinical presentations, like when we will say clinical illness, equivocal and well appearing. Illness is described as persistent need for NCPAP or HFNC or mechanical ventilation. If the baby is hemodynamic unstable, requiring vasoactive drugs, the baby had neonatal encephalopathy or perinatal depression, like baby had features of seizure, Wabgar score of 5 minutes is less than 5. There is need for supplemental oxygen for more than equal to 2 hours to maintain oxygen saturation of 90%. Equivocal, if any of the four, like persistent physiologic abnormalities for more than 4 hours, like tachycardia, tachypnea, temperature instability, respiratory distress, or four more physiologic abnormalities lasting more than equal to 2 hours. It is tachycardia, tachypnea, temperature instability, respiratory distress. Will appearing if there are no persistent physiologic abnormalities. So, for example, when we just enter this, like we are doing in the updated 2024 calculator, the incidence, for example, I put 1 in 1000 live in the gestation 36 plus 5 week, has maternal temperature as 104, rupture of membrane with 24 hours. The GBA screening, for example, it is done and it is negative, and the mother received broad spectrum antibiotics for rupture of membrane. By just clicking on calculate, it showed that the risk is 12.69. And if after clinical examination, if the baby is well appearing, the risk is 4.6 equivalent 40. If there is clinical illness like heart severe respiratory distress and all, the risk is increased to 157 per 1000 birth. And clinically, it is recommended that to provide empirical antibiotics and vitals monitor in the NICU. While going to the calculator, there is information where it has been shown that if practicing in a country or area not using universal GBA screening, for example, like in India, we suggest continuing to use the original 2017 model. So with the same predictors, when I am using the original 2017, we can see here the risk is more. Like in Indian setting, when we use the original calculator, the risk is 25.5, and even with a similar clinical presentation setting, the risk increased. So what is the sensitivity of this calculator? Can we use it? So as per the latest systemic review and meta-analysis, sensitivity of Kaiser Permanente early onset calculator published in 2020, it has the findings are they have taken 11 studies where a total of 75 EOS cases across the studies, and a minimum of 14 best case scenario and a maximum of 22 worst case scenarios, where use of calculator would have resulted in delayed or missed treatment compared to if NICE guidelines had been followed. The interpretation was large proportion of US cases were missed by the calculator. Further evaluation of calculator is recommended. What about Indian setting? This is the latest randomized control trial published in India, done in the Mahatma Gandhi Medical College, Puducherry. The safety and efficacy of early onset sepsis calculator among at risk for sepsis units born at more than equal to 34 weeks. So they have taken 180 neonates of more than equal to 34 weeks. For the result was 20.9% of neonates in the SRCs sepsis risk calculator received antibiotics compared to 59% in the standard clinical guideline group. The number of septic screens performed was reduced by 36% in the SRC group with a comparable reduction in the blood culture, that is 37 in the SRC group versus 69 in the SCG group. There was no significant difference in the length of hospital stay between the groups. Well, what they concluded is the implementation of US risk calculator effectively reduces the unnecessary antibiotic uses in at-risk neonates without compromising the patient safety. Well, but depending upon only one RCT, we cannot apply this in Indian setting because there are many pitfalls of this calculator in the Indian setting. The most important is overall, it cannot detect in babies for less than 35 weeks. So the first is, it is derived from the high income countries, not in LMIC or middle income countries like in India. Second is inadequate maternal data availability in Indian setting, and resource limited monitoring, late presentation and referral bias, different epidemiology of sepsis. Because in US, there is gram positive, the GBS setting, where in India, gram negative sepsis is predominant. There is no routine GBS screening in India. The risk of missed or delayed sepsis and low sensitivity at birth. As per the suggested calculator, the sensitivity at birth is only 48%. Under 24 hours is 80%, but we cannot wait for 24 hours to decide about antibiotics. So depending upon all the pitfalls, what NNF 2021 position statement recommended is not using the various early onset sepsis calculator like UNS calculator by Kaiser Permanente developed in high income countries for the management of well appearing asymptomatic neonates born after 35 weeks. So the risk of the recommendation is weak with low certainty of evidence. But in selected units where predominantly infant units are treated and maternal group B streptococcus colonization is an important risk factor for EONS, this calculator can be used. So depending on that, what is the disease resistance rule for antibiotic resistance? So as per the NNA, we can follow as in the previous lecture what is already said. Look for symptomatic neighbors at any gestation with having maternal or perinatal risk factor of sepsis. The guidelines suggest to use antibiotics. For more before 35 weeks, if the baby is more than 32 weeks, to give antibiotics if any red flag or to more than equal to 2 red. For less than equal to 32 weeks, either 1 red or yellow flag risk factor. The most important is towards the antibiotic stewardship. In case the antibiotics are started, the guidelines suggested that may be stopped after 36 hours if the blood culture remains sterile and the baby's clinical condition remains stable. These are the yellow flag and red flag risk factors as per the NNF guideline. Well, we have guidelines for EONS. What about late onset sepsis? We have, for example, we have admitted one 4-day baby with his in the emergency with history of just 1 episode of fever, and on examination baby is clinically stable. In that case, we need the biomarkers. Though these biomarkers like procalcitonin, interleukin-6, and the neutrophil to lymphocyte ratio studied for both early onset sepsis and late onset sepsis. Coming to the first, procalcitonin. Procalcitonin is a precursor of calcitonin. It is normally produced in thyroid, but during infection, produced systematically by liver, lungs, and intestine. Strongly stimulated retrobacterial introduction starts rising within 2 to 4 hours and peaks at 12 to 24 hours. Remain elevated for 24 to 48 hours and falls after 48 hours if treated. As per the latest systemic review and meta-analysis, the sensitivity varies from 87 to 100%. That is a good sensitivity, but the specificity is poor. It is 17 to 89%. So the variation in diagnostic accuracy between studies suggests that the procalcitonin may be useful to guide antibiotic cessation, but should not be used alone as a diagnostic marker. And the important is also cost factor and whether it is available in all the facilities or not, and the cost is nearly 1,000 to 2,000 rupees. Second is coming to interleukin-6. It is a pro-inflammatory cytokine released by monocyte macrophages endothelial cells, fibroblasts, and triggered rapidly after bacterial invasion and starts rising at 2 to 3 hours. Peaks at 6 to 12 hours, falls at 24 to nearly 24 hours. As per the latest systemic review and meta-analysis, the sensitivity and specificity are nearly 85% with a balanced accuracy. That means it suggests supports both ruling in and ruling out late onset sepsis. But the limitations of cutoff variability. Many of the studies have taken the many cutoffs, but most of the study in this systemic review, they have taken almost 2/3 of the studies taken a cutoff of more than 20 picogram per ml. The studies for interleukin-6 are mostly from high-income countries and middle-income countries, and it is costly nearly 2,000 to 5,000 depending upon the facility. The third is neutrophil to lymphocyte ratio. So what happens in acute infection, bone marrow releases neutrophils rapidly. This causes the absolute increase in the absolute neutrophil count. With the response to stress, the lymphocyte apoptosis occurs, decreasing the lymphocyte, and the result is increasing the lymphocyte ratio. In studies, the various cutoffs are taken, but most of the studies, those are mostly cross-sectional and cohort studies, they have taken a cutoff of more than 2 to 3. With a variable sensitivity and the specificity, the strength of neutrophil to lymphocyte ratio is cheap, and day-to-day practice we are doing CBC where we can assess this. And the limitation is lower accuracy and of variability. So what is the decision rule? Which biomarker to add when CRP is equivocal? It depends upon the biomarker at a different phase of sepsis. The choice depends on the timing, presentation, clinical stability, and also the availability of the biomarker and cost. But when there is early suspicious, as interleukin-6 rises early, we can use interleukin-6. Procalcitonin if within 6 to 12 hours for the confirmation just to rule out sepsis if the baby is nearly clinically stable. And neutrophil to lymphocyte ratio, the variable rise we can use best as an urgent or trend biomarker along with interleukin-6 procalcitonin. What about the decision rule for antibiotics depending upon these biomarkers when the CRP is equivocal? Like high probability start antibiotics if any of the above are high, or if there is strong clinical suspicious where suspecting yes, the baby is clinically unstable, we have to start without any delay while awaiting for the blood culture report. Intermediate, if there are mild clinical signs, only one marker is borderline, action is there, we can wait and repeat markers at 12 to 24 hours and monitor closely, considering starting antibiotics if there is any worsening or the repeat marker is in increasing trend. Low probability is the rule out zone. Clinically, baby is clinically well and the procalcitonin or IL-6, whatever you have done is normal. We can withhold antibiotics or stop antibiotics if you have started. So my take-home message is an integrated decision tool combining clinical assessment with biomarkers. Those are CRP, interleukin-6, procalcitonin, and neutrophil to lymphocyte ratio. It provides most reliable strategy for yearly prediction of neonatal sepsis, enabling safe antibiotic stewardship while minimizing the missed diagnosis. Thank you. The learning point in this is in day-to-day practice, we are not using, most of the centers are not using neutrophil to lymphocyte ratio. So we can start using this in our day-to-day practice. Thank you.
Thank you, Dr. Monalisa. I will request the little first teams to please take over.
Hello. Am I audible?
Yes, Dr.
Yes. Good morning, everyone. So today we from the Little Fun going to talk about the cultures, which is a crucial thing in sepsis diagnosis. That when to culture, what to send, and how to interpret the culture. So always when we treat the sepsis, there is a risk of over-treatment and under-treatment. Of course, if we under-treat the patient, there is a risk, high mortality rates of up to 30% in early onset cases. And if we over-treat the cases with antibiotics, there is a risk of antimicrobial resistance. So our goal should be the accurate diagnosis with minimum harm. So objectives of the scope of this presentation is when to send culture, that is to discuss about the trigger criteria, how to send culture, that is to discuss about the 3 non-negotiable things while sending the blood culture, and third thing, how to interpret this growth, that is to decide between the contaminant versus pathogen. And we will be discussing a clinical scenario where a positive culture in a well baby, what should be our approach. So coming to the first thing, that is when to send culture. Always there are 2 kinds of triggers when we before sending the culture. First is a clinical trigger where we assess the baby systematically to look for any temperature instability, hypothermia, or fever. If there is any kind of lethargy, poor feeding, refusal of feed, then there may be an increase in requirement of FiO2, increased distress and apneic episodes. There may be a perfusion-related issues like shock, prolonged CRT. And there can be, in late onset sepsis, there can be history of seizures or abdominal distension and feed intolerance. Coming to the biochemical thresholds. So in case of biochemical thresholds, we always see for the CRP, procalcitonin, and abnormal CBC, that is total leukocyte count less than 5,000 versus the total leukocyte count more than 25,000. Low absolute neutrophil counts and IT ratio more than 0.2, and the thrombocytopenia. always there we should look for this high risk settings also for like any kind of prematurity, very low birth weight babies, extreme low birth weight babies. If there is a history of premature rupture of membrane more than 18 hours, if there is a maternal history of fever or any signs of chorioamnionitis, and if intervening line is present in the neonate, like central line, PICC, and umbilical venous line. So always we should, while looking at the biochemical threshold, we should look at the trends and not a single value. And blood culture should always be sent before starting the first dose of antibiotics. To align to this, surviving sepsis campaign 2016 also establishes that we should start the antibiotics before 60 minutes only. And we should we should be sending the 2 sets of blood culture before starting antibiotics, provided that it should not delay the antibiotics by more than 45 minutes. So talking about the biochemical markers, there was a large randomized control trial that is
Sorry, Dr. Avinash, is it my speakers or you're not audible?
No. I think Avinash, some issue with your microphone, or maybe you're covering your microphone laptop.
Okay, sir.
Now it's better.
Yeah.
Yes.
And can you please repeat from previous slide? Like
Yes, sir. Yes, sir.
Sure. Thank you.
From this, should I continue?
Just start. You can start with key principles.
Next
We'll
one.
do Next part.
Okay, sir. So Surviving Sepsis Campaign 2016 also establishes that we should start the antibiotics before 60 minutes, and we should send 2 sets of blood cultures before starting antibiotics, provided that we should not delay the antibiotics more than 45 minutes. Coming to the biochemical triggers before for sending the blood cultures. So there was a large randomized controlled trial called as NeoPINS trial, which helped us to guide about the procalcitonin role. So what they have done, they have got the risk classification based on the clinical symptoms, maternal risk factor.
Avinash, sorry, I think same issue. Are you not in a good network?
Network?
You're in Wi-Fi, no?
Yes, sir. I'm on a.
Yeah, it's just something, or maybe just keep the laptop on the flat surface. It might be touching, the microphone is getting blocked. Your sound is coming muffled.
Now, sir?
Now it is better.
So talking about the NeoPINS trial, sir, which help us regarding the role of procalcitonin. So this was a large randomized controlled trial where they have stratified the baby into the 3 groups, like infection likely baby, infection possible baby, and infection unlikely baby, based on the 3 criteria. First criteria was a clinical symptom, second criteria was a maternal risk factor, and the third criteria of basic lab that we have talked in the biochemical trigger section. So they have found that the procalcitonin help to reduce the antibiotic duration significantly by 10 hours and reduce the hospital stay. The total length of stay was significantly shortened, and it proved the safety also, that 0 sepsis related cases deaths were reported during this trial. So 2 sets of procalcitonin help to assess the prognosis in this case. So these while assessing the procalcitonin, also there we use the normal age adopted procalcitonin ranges. Physiologically, procalcitonin rises between the 24 to 36 hours of life and then comes down. So while assessing the procalcitonin, we should consider this physiological rise also. And these are the charts we use to assess the absolute neutrophil count in term and low birth weight babies. So we have decided when to send cultures, that is if any subtle clinical signs of sepsis are present, or abnormal labs, or any risk factor is present, or if the high risk infant is deteriorating on the ongoing antibiotics. So coming to next, what to send. So blood culture is the remains the gold standard, and it is the mandatory thing. But what should we consider additionally? If babies, we have a suspected late onset sepsis, or if baby is having seizures or suspected case of meningitis, CSF culture is mandatory. Also, if unexplained late onset sepsis, urine culture is mandatory. If baby is ventilated, then ET aspirate cultures we do. And in case of indwelling line or CLAPSI is suspected, then line culture is mandated. So how to send the blood culture? So there are 3 non-negotiables that we should follow while sending the blood culture. First is the volume, which yields that which is a yielding driver. Minimum 1 ml of blood should be sent, and we should always use a 2 ml syringe to avoid that air thing. The volume less than 0.5 ml reduces the sensitivity by 40% and yields the false negative cultures. Second thing is timing. We must withdraw blood culture at the onset of sepsis and before starting the first dose of antibiotic or before changing or upgrading the antibiotics. And third thing is the site. A peripheral venous site is preferred, and if we are suspecting a CLAPSI, then we should always send a paired culture from periphery and from the line also. So we should always remember that the poor technique guarantees the poor interpretation and poor false results. Also, there are a few pitfalls like if we collect the inadequate volume, or if we draw the blood culture from existing IV lines, or there is a delayed sampling post antibiotic administration, or there if we follow the poor aseptics technique while collecting the blood culture, then we may get the false results. Now, once we send the culture and report comes, there comes a report, and if that report is showing some organism, how to proceed and how to differentiate between the true pathogen and the contaminants. So there is a 3-step framework to differentiate between a true pathogen and contaminant. Step 1 is to look at the organism. So likely pathogens are gram-negative pathogens like Klebsiella, E. coli, or Candida fungal growth. But if the culture shows the cons or diphtheroids, it is likely a possible contaminant. Second thing, look at the baby clinically. See if baby is symptomatic or asymptomatic. See the lab parameters like CRP, procalcitonin, and CBC, and see the hemodynamic stability of the baby. And third thing, see for the time to positivity. Most of the true pathogen grow early, that is less than 24 hours. And if we are in doubt, we should repeat the culture and see for the if same pathogen grows in the next culture. A rapid differentiation between the true pathogen and contaminant. In case of true pathogen, baby will be sick and unstable hemodynamically, and in contaminant, babies generally are well. Look at the organism. That baby, that organism will be the virulent pathogen in case of true pathogen, and it will be a skin contaminant in case of contamination. Time to positivity, usually true pathogens grow less than 24 hours time, and contaminant will take a significant amount of time, and it will be a delayed reporting. And if we do a repeat culture, in case of pathogen, the same bug will grow, and it will be a negative in case of contamination. Coming to a clinical scenario, that is, if what if a well baby grows a culture positive? So this approach should be, we should look clinically towards the baby. If there are sudden, subtle or hidden signs of sepsis, we should check our biochemical triggers like CBC, CRP, and procalcitonin. Again, a single value is should not determine the course. We should look at the trend. We should assess for any central line, peripheral lines, or umbilical lines. We should review our sampling technique and look at the time to positivity to grow the culture. And we should observe such a babies for almost 24 to 48 hours and repeat the culture. A culture report should never override the bedside clinical assessment. So this is our algorithm. First, we should suspect the sepsis based on the clinical or biochemical triggers. If we are suspecting the sepsis, we draw a blood culture with 3 non-negotiables, that is adequate volume, adequate site, and it should be sent before starting or changing the antibiotics. Then we should treat the sepsis with the empiric IV antibiotics, and it should be started within 60 minutes of suspicion. If at the end of 36 to 48 hours, cultures are negative, baby is stable, and procalcitonins are normal, we can stop the antibiotics. If the culture is positive, it should be interpreted with the help of 3-step framework and targeted. If there is a true pathogen, that full sepsis workup should be done, and we should narrow down our antibiotics. And in case of doubt, always send the repeat culture and look at the trend of CRP and procalcitonin. So this is what we have talked. The critical intersection. If culture is negative, procalcitonin 2 consecutive readings are normal, and baby is clinically stable, then we should stop the antibiotics. So coming to the high yield points, that volume determines the yield in case of blood culture. One good blood culture with our 3 non-negotiable things is far more better than multiple poor blood cultures. Cons is not always contaminant. Think of the line sepsis. Always we should correlate the reports clinically. We should stop antibiotics early if safe. We should not culture blindly. We should not ignore the positive culture. Technique is important in case of outcome. And interpretation should be always based on the clinical and microbiological diagnosis. Cultures should be sent when the clinical and biochemical triggers are met. More than 1 ml blood volume should be collected while sending the blood culture. We should always send cultures before starting or changing antibiotics. We should use the structured interpretation. And culture negative sepsis should promptly should prompt daily antibiotic review and early de-escalation whenever clinically feasible. So these are the references. We should treat the baby, not just the culture. We should support the culture with 3 non-negotiable things, and we should rationalize the antibiotic. Thank you.
Thank you, Dr. Vinash. Now we have the GreenNet talk by the graphic era team. Till then, if you have any comments, any doubts, the floor is open for that.
So, good morning. Am I audible, sir?
Yes, Dr.
So, I'll just share my screen. Okay, so today we talked in detail about neonatal sepsis, but for the GreenNet talk, what I am doing is I'll be going to the basics of neonatology, to the history of neonatology in India. So with this, a very good morning to Adarniya Gurujis, my respected seniors and my colleagues. When we are asked a question that how old is systematic Indian neonatology practiced, how old this is, some of us may answer that it's 50 years old, maybe 100 years old, 200 some may say. What if I told you that Indian neonatology started 5,000 years ago? 5,000. So with this introduction, I'll be talking about Giri Neo Sangam. It is a syncretic compendium which is a confluence of ancient Indian and modern neonatology. So with this talk, I have 2 or 3 basic objectives. First, I want to create an awareness about the history of Indian neonatology. I would like to feel everyone, each one of us, to feel appreciative and proud to be flag bearers of such a rich history that we have here. And we could take out some points to move forward in today's time. So with this, let's move forward. I'll talk about the timeline. So this is the timeline that I'm talking about. So Indian neonatology started around 5,000 years back from 3000 BC in the Indus Valley civilization. Following that, progressively through Atharva Ved, Sushrut and Charak Samhita, Kashyap Samhita, Patanjali Yoga Sutra, Vagbhat texts, till the conception of modern NICUs in the 1960s and further. So this is the history that we have before the starting of the modern NICU. So here we have details about these timelines. Now, one thing that we practice in every delivery now in India, all around the world, is neonatal resuscitation. So what you can see on screen is something on a similar line with all the objective flow charts, which step to follow which has been mentioned in an ancient text known as Navjat Shishu Paricharya. So we can see that what we practice today based on evidence, this has been going on for so long time. So in this, we'll talk about some specific terms because time is a bit limited to talk about everything. So I'll talk about some specific parts of this neonatal resuscitation. So first thing that is mentioned is Prana Pratyagaman, mentioned in Charak Samhita and Sushrut Samhita. It meant sensory stimulation for resuscitation. So today, modern correlate for that is tactile stimulation, suction, and PPV that we practice today. Then there was something known as Nal Chedan, that was delayed cord cutting, that was practiced at that time also. And we know that today, delayed or deferred cord clamping is a standard of care and is a grade A evidence we have for that. Then we have something known as Abhyang, that was daily medicated oil massage, mentioned in Sushrut Samhita. So presently, we have emollient therapy, which has been formally recommended by WHO and which we practice in our NICUs today also. Then we had a concept of Sutika Gar, that was a dedicated warm birth room with restricted access with all the asepsis protocols. Today, this correlates with our modern NICU design, rooming in infection bundles, and the thermal care that we practice. And another important thing was something known as Nad or Rag therapy. That was music and Vedic chanting for the well-being of newborn and the mother. So today, NICU music therapy is an upcoming thing, and research is going on that for newborn well-being. So these are some of the things. There are many things, but these are some of the things that correlate well from that time to today's NICU management. Then
sorry, honey at birth correlate to glucose.
Yes, sir. Yes, sir. I'll talk about that a bit later, sir. I'll talk about it, sir. Just a bit. So here it is. This is the umbilical cord management tree. We have combined the ancient and today's wisdom to make this. So this is just for your visual assessment. Now, this is the oil selection technique. So in the ancient texts, everything from which oil to use, in which season to use, how to use, everything has been mentioned and when not to use. So we are also practicing that today. There was something known as this Nada Brahm, that was different type of these ragas at different times of day, including Bhairavi, Raga Kafi, Hans Dhwani, for the well-being of neonate and the mother. So we have some evidence for this today also, like we have evidence for Brahmari Pranayam for mother practicing before KMC, maternal lullabies, we have evidence. So this is something that we can take forward from here. Now, this is where I wanted to talk about what sir said. This is the evidence pyramid that we have today. So first, we have many things, most of the, let's say 60 to 70% of things that are RCT validated today. Some things have moderate evidence, including turmeric care, shatavari lactation, ajwain as antispasmodic. Some things are emerging and they need further RCT, further research to tell whether they are useful or not, including Swarna Prashan, Rag-specific NICU therapy, Bal-Tal emollient, and very less things. In whole, if you will study the document, you will find that almost only 4 to 5% things are contraindicated. They have become contraindication today. And that includes honey in less than 12 months. Another thing is open flame fumigation near neonate and mustard oil in less than 32 weeks gestation. So this is a part, definitely there is a part, but it is a very less part. And we have a segment which shows the critical cautions and contraindication. So we have this honey part on the first point. This is absolute contraindication. Then we have some things which should be used with caution. So we have mentioned it here. And in this module, there are some comprehensive FAQs for clinicians, academicians, researchers, and innovators. That what are the general questions that can be there, and how to answer that from this research. I'll just move to the next thing I want to talk about, and this is what we can take out from this, what we can move ahead from this. So India is uniquely positioned to lead the global research agenda in syncretic neonatology. So we have both Ayush infrastructure, we have modern establishment, and we have documented neonatal care literature, which is the oldest in the world. So we have brought out some priority trials that can be done. In this session where we have so many esteemed institutions participating, these trials can become part of a multi-centric trial under ICMR umbrella, and with these we can give back to the world something from our own roots. So one of them is turmeric versus chlorhexidine versus dry cord care RCT. There is Schwann-Praschen immunomodulation RCT. There is Baltel that was used earlier versus coconut oil RCT. Then music therapy in NICU, multicenter RCT can be done, and Shatavari lactation RCT. Obviously, any of this should have its own. We should be careful. We should be careful about the neonatal well-being and everything. So what should be considered is also mentioned here. So this is what we can take forward. And there is a complete reference suite that has been used for this. So the time was a bit limited to talk in detail about this, but what I can say is, I hope I have been able to fulfill the objectives that I started with. And there is an ambitious proposal from my side for all the esteemed institutions here, that any neonatology curriculum here in India should start with a history of Indian neonatology. So that would be very helpful, and this compendium would be helpful in that if that materializes. And before the close, I'd like to say special thanks to Surgeon Rear Admiral Dr. Girish Gupta sir and Dr. Nani Puri for authoring this compendium. This work reminds us that while our technology is modern, our legacy of neonatal care is deep, very long, 5 millennia deep. And I'd like to thank them for their vision in bringing these two worlds together. Thank you all. I think I hope I have generated some interest for this in you, and I'll be happy to share this document for further perusal for all the respected people. Thank you.
Thank you, Dr. Abhimanyu, and so good to listen that our history is so rich, and many times we actually ignore it.
Yes, sir.
And definitely, if you could share this document on the group so that all of us can go through it.
I would do that.
Sir, definitely. So now the house is open for any comments or discussion from any of the team.
Quickly, I would just say, this was an excellent and I think a very high confluence of all the institutes, like very comprehensive. We finished in time as well today, and there were some really, very nicely consolidated insights on sepsis. And then at the end, it was refreshing to hear to Dr. Abhimanyu. He brought in some perspectives that actually bridges the ancient and the modern neonatology. And yes, we would love to be part of any of those proposals that you brought out today. And yes, as Dr. Chinmay said, kindly do share it with all of us. And in fact, also, I thought when we were seeing those slides from NeoObs and the Dennis study, the DH study, so probably since we 6 centers across the India, all like from a private setup, a corporate setup, and a public institute. So I think that also again gives a opportunity for a collaborative multi-center AMR data platform that we can really bring out. So well, that's all from my side. Thank you.
Yeah, good morning, everyone. I think all the presentations were very crisp and very nicely made PowerPoint slides. And Dr. Abhimanyu, thank you for that excellent presentation, and to be aware of the rich history that we are part of that is necessary for all the upcoming neonatologists. And I second the opinion of Dr. Akanksha, what she said, like any of these thoughts are cities which were talked about, we can do a collaborative research among all the institutes who are part of NHISGI. Thank you.
Yeah, I would like to comment. I think that's what today was really great. Already a lot of things has been said. I think this is a good pattern that we enlist exactly what needs to be covered in the each lecture, stick to the topic, stick to the time, and I think comprehensively cover the topic. And again, very interesting presentation, Dr. Abhimanyu. I think you just sparked a new sort of direction in which even personally I was very interested that just couple of my experiences I would like to share. Uh, First one was when I was in Canada, we were working, they were trialing out a secret solution, which was, and they wanted to do an RCT. And then we opened the solution, it was yellow. I was like, this looks like turmeric. I know what is that yellow ingredient. And they were trying to show is Dr. Go's something solution. And like this is cheating, so I think somebody patented the turmeric by that time. So I think that's where we could hold the our patent on turmeric as a healing. So it was a trial for healing a wound, best wound care. Secondly, when I was in New Zealand, we were center for the glucose gel trial. So then we discussed, like glucose gel, and I said this practice of honey has been there in India for many years. Then I looked at the content. I think honey is more of glucose and fructose. So I discussed that time with Professor Patole that we should do an RCT or something like that. Why glucose gel? I think the practice of honey was actually must be because there must be some evidence of hypoglycemia. We don't know, uncontrolled diabetes, IUGR, malnutrition was high. So to maintain that initial sugars, they started this practice. But obviously, I was referring to conduct this because of the contaminated issue. And if we do some RCT like that, and then there are more studies, the whole effort which is taken by IAP or NNF and all the institute to take away the honey in first year, because the bottlenecks of war is so high. So I think we sort of refrain from doing that RCT. But definitely there is some science behind it. I am not saying that we should probably do this RCT, but I think the whole idea about early glucose gel or early even express colostrum. So I think one more practice which I don't see in India is like express colostrum before the delivery. So you have something to give at the time of delivery or just soon after for preventing hypoglycemia. Those two things are really good. Shatavari, also, I think you highlighted, I think everyone is so convinced. I don't think anyone will be waiting for RCT. Like I think every mother in India gets Shatavari, but very well documented. We should probably document it with an RCT so that we can back up confidently. So I think we are also open for this kind of fun RCTs. We have 3 centers now, almost 55, 60 beds. So we should be able to contribute also to that. So we are very happy to participate and very well presented by everyone. Thank you.
Even sir, I'd like to add the sound therapy one thing. So it is starting. It was so well documented in our literature, and it is already starting in the western part. The research is already starting there. So why can't we take the forefront and we can we have so many beautiful things for that, and we can give it back to the global neonatology. So That is the only thing.
So just to share, I'm Dr. Girish Gupta's student, and in 2004, during my residency, we were doing the this. So sir, obviously, sir remembers, but I remember bringing the Gayatri Mantra CD. We used to have a speaker in our NICU, and we used to play. That time, there were CDs were there, no iPods. So CD had come up, was a new thing. So CD player we used to have and connected to the microphone, no Bluetooth and all. So we used to play those CD. So morning ragas and Gayatri Mantra. And sir used to also tell us to bring those cassettes, somebody with the microphone, somebody can record their voice. And we had one CD of uterine, so full sound also. So this is back, we are talking 22 years ago when Dr. Girish Gupta was our HOD and I was his student. So at that time also we used to do this. And always wherever I went, we try to sort of replicate this, but you know, there are a lot of practical challenges. But if there's a drive, we should do it. So maybe Gupta sir, if he's around, he can comment on that. I remember collecting those CDs and cassettes and mothers, encouraging mothers to record their voice. And there were mothers who actually recorded. And I'm sure in your unit also, this must be happening still.
Yeah, we have, yes, we are doing. So we can, yes, we are doing on the individual level, but we can maybe, get some evidence for this, and we can make it more prevalent in our Indian NICUs and the global NICUs also. So, thank you, sir.
Comment from Wadia or any other institute? Comment from Dr. Girish Gupta, final comments.
I'm waiting for the comment of General Daljit. Anything from
Wadia, anyone from Wadia?
Wadia
Institute.
AIMS.
Good question. Thank you.
I think it is probably one of the finest sessions which we had today. The contents were so well decided. Well done, Dr. Kiran, for giving a very defined role. And secondly, in addition to the content, the quality of slides were, I wanted to give gold medal today to presenters. It has been so beautifully done, content and template wise. So I think a brilliant job. Maybe if people like and bring some competition in this session, we can have the best presentation and the best content and template wise. One could think about it, Kiran, so that there is some more motivation to the presenter and we'll have more practices coming in. And gradually we'll inculcate our practices also in our presentation. Because until we share some information, some of our practices, it essentially remains a theoretical presentation. So one could think about it. And of course, depending upon your privacy of data and all that, we'll not share. But within the group, we can consider doing it. So I think it is excellently done. Thank you very much. And my job is then, I wanted people to get sensitized about ancient Indian neonatology, and which has been put in the forefront. And Kiran did mention about the sound and things like that. We had done, in fact, we have many researches on sound in intensive care. So sequential trials, use of Om, use of Gayatri Mantra, and many more. So one could consider of doing together some collaborative trial. With this, I'll conclude. Thank you, everyone. Wonderful job. Have a great day.
Thank
you, sir.
All right. Okay.
Okay.
Thank you. I think we can close the session if there are no final comments.
Kiran, you need to talk to me later in the day. Okay.
Yes. I'm going to call you in the afternoon, sir. With the final plan. Yeah.
Thank you.
Thank you.
Thank you. Good day.
Thank you.